And we really want this session to be a forward-looking dialogue to reflect on how we can better finance community health worker programs and explore what innovative approaches we should be looking at in order to build more resilient, looking at really pioneering and pushing on country-owned systems integrated with broader primary healthcare reform. So before I introduce our panelists, I'd like to get a very quick sense of the room and what people are thinking, what people are feeling. So we are launching a Zoom poll right now. It should pop up on your screen. And the question that we are asking you is, what is the biggest barrier to sustainable CHW financing in your country or in your organization? Please type your answers. And as you type your answers, tell us where you're joining from. Tell us what you think. Again, the question is, what is the biggest barrier to sustainable CHW financing in your country or in your organization? Whatever pops into your mind, whatever comes into your mind first, and we'll read a few of those responses to get a sense of where everyone is from. We have Bangladesh, we have Cambodia, that is so amazing, Madagascar as well, Somalia, we have Nigeria, Valerie from Cameroon. Thank you so much for joining. And if you're joining us right now, we are just quickly doing this poll on the biggest barrier you think you face as an organization or as a country, whatever level you're at on CHW financing. And then we can get straight into the discussion. All right. Just keep on sharing your views, your thoughts. And yeah, thank you very much for participating and sharing where you're joining us from. And we hope that as you're reflecting on these challenges that you're facing, the barriers that you're facing, we hope that by the end of this webinar, you'll be able to look at them as opportunities, really, and see it in a different light or, a different perspective. So with that, let's now dive straight into our discussion. We're delighted to have a very rich and diverse panel all the way from Guinea-Bissau to Senegal, to Sierra Leone and Indonesia. And to start us off, I'd like to welcome our very first speaker, Elizabeth Musa. She is from the Ministry of Health in Sierra Leone as a National Community Health Worker Coordinator with extensive experience in community health systems and primary health care. And she'll be sharing a little bit more on how Sierra Leone has integrated CHWs into the national health strategies and MOH system at a broader spectrum. So thank you very much, Elizabeth. Go ahead and take us through your presentation. Over to you.
Thank you very much, Maya. So good morning, good afternoon, and good evening to everyone. I'm going to present on behalf of Sierra Leone the role of global health actors in supporting sustainable financing, specifically in Sierra Leone. Next. So to give you a background of the CHW program in Sierra Leone, we have over 8,000 CHWs integrated in the national health system through trainings, recruitment, supervision, management, etc. And our CHWs provide basic community-based services, mostly preventive, promotional, and basic curative, including immunization, ICCM, malaria, RMN-CAH, surveillance, etc. CHWs are paid incentives between $15 to $30 on a monthly basis. And we have community health workers in hard-to-reach areas and easy-to-reach areas, and also their peer supervisors. There is currently increasing recognition of CHWs as a critical pillar in delivering PHC services and achieving universal health coverage. There is no doubt about that one, because this one is being anchored and spoken everywhere, including the president, the Minister of Health, and all other partners. Commitment has been shown through the updated CHW policy, strategy, and other national policies, including the Human Resource for Health Strategy, the National Health Sector Strategic Plan. Next page. Our key progress and opportunities. We have, as I've already said, we have a national CHW policy updated that aligns with the PHC and UHC goals. There is currently a CHW hub, a unit created within the Directorate of Primary Healthcare, responsible solely for management, leadership, and coordination of the national CHW program. And it is situated within the Directorate of Primary Healthcare. So one of the achievements is the CHIS that we have linked with the DHIS2, meaning we can currently get individual CHW data from the DHIS2. There is a momentum to establish a dedicated budget line for CHWs, and there are also opportunities for joint financing models. This momentum is started from within the Ministry of Health, where the Minister of Health is currently championing the sustainability of CHWs. So we need an investment case, and our minister is currently waiting for us to develop a return on investment and an advocacy deck, which he is going to start using to advocate at all levels for domestic financing of CHW program. So we are in the process of finalizing the sustainability plan and also a reform measures for up to year 2030. Is currently going on a complete reform for the CHW program in Sierra Leone. Next slide. Our financing landscape. Financing is largely dependent on external donors, including payment of incentives to CHWs, because our CHWs are not on salary. And the donors are Global Fund, Gavi, US government, UNICEF, World Bank, LAD, and other bilateral partners. The funding stream remains fragmented and disease-specific, like HIV, TB, malaria for our Global Fund immunization. This is specifically for some donors, although we sometimes integrate the money and do a harmonized implementation. There is no domestic budget allocation, no budget line for CHWs, recurrent costs. But in the current fiscal year, we have already started requesting for CHW budget line within the government, the Ministry of Health annual budget allocation. And we are waiting for the response from the Ministry of Health. Next slide. Our key challenges we are the government, Sierra Leone is heavily reliant on vertical and donor-driven funding, which threatens sustainability and making sustainability to be at a risk. So we are in the process of transitioning to domestic financing, but it is still limited. And we are waiting to hear the response from the politicians. There is inadequate supervision and supply chain support for CHWs, to mention but a few. Next slide. So this is just a handful of our peer supervisors supervising their colleagues, and they have just undergone a training in community health information system with their gadgets, and they have been qualified at the end of the training. I thank you all for your attention.
All right. Thank you very much for that very insightful presentation. I see that there are already questions that are coming in for Dr. Elizabeth. Please hold on to those questions. Keep typing them in the Q&A chat box. We're going to be collecting all of these questions, and we'll ask them after each of our panelists have presented their different topics. Now let's shift gears now and hear from a very special case in Guinea-Bissau. I am delighted to introduce Andrea Speranza, Community Health Specialist at the United Nations Development Program in Guinea-Bissau. And Andrea is going to give us a bit more context on what role global players such as the UNDP are playing right now on country-led solutions, as each country has its own challenges and different issues that needs to be addressed. But just to give you a bit of a background as far as Andrea's experience is concerned, he's worked with several NGOs in different regions from Kosovo, DRC, Gabon, Yemen, Rwanda, Senegal, Kenya, and lately Guinea-Bissau. And has quite a bit of experience, having served as well under the World Bank as a health consultant, and currently now in Guinea-Bissau. So over to you, Andrea.
Good morning, everybody. Good afternoon. Greetings from Guinea-Bissau, which is located, as you see, in West Africa, just south of Senegal. It's a small, wonderful country. 2.3 million people. You can go next. And yes, we're at the 174th position in UNDP Human Development Index in 2023. So the country is marked by a frequent turnover at political level. We are going to have next general elections in November, so big turnover in which does not help in coordination with the partners. The package implemented by the community health workers is the package, ICCM package, key family practices, with a focus on gender, human rights, and inclusion. They are still paid as the case from Sierra Leone, community selected volunteers, not formally integrated into the health system. They received a monthly incentive, performance-based, based on the community, on the household visits. We have an issue of gender. We have only 15% of female community health workers. It was last year. They are actively involved in mass campaigns. We don't have at the ministry level a directorate of primary health care. So this is also, it can lead to fragmentary imported lines across different directions. We have an opportunity, though, in the next future, we are going to develop the new community health strategy for the next 4 years. Next, please. The present picture of the community health financing is really similar to the one described by my colleague from Sierra Leone, so I'm not going to take a long time to describe. We rely heavily on external funding, and there is a high fragmentation as well. The main donors in the past was the European Union. Now is this World Bank and the Global Fund through UNDP as a principal recipient. Susan Thompson Foundation stepped in. Gavi will also step in from 2026 onwards. Though in recent times there have been some good efforts to enhance complementarity and avoid duplications, so we have improved. Technically, the government is supported by some main agencies like UNICEF, WHO, and UNDP. There are several international NGOs which have been also contracted for the implementation of the field work for the last years. There is a transition phase to the regional health directors, which is started in 2019, but it's still ongoing. So this is the present picture. Next. The challenges regarding the financing. So we're going to shift from a scenario, the present scenario, which foresees the 100%, we can say, of the activities which are funded by foreign donors, to a new situation, a new scenario, because we have anticipated reduction of some fund resources. And also some of the main grants are coming to an end soon. So the scenario will radically change. We have a scarcity of funds from the outside. So that this means that that's the time of the stepping in from the government. Unfortunately, from the government side, so far we have limited domestic allocations to the health sector as a whole. We are still far from the goal of 15% of allocating the general state budget to the health sector. We are only between 6 and 7% in recent years. We also have, of course, competition from inside Minister of Health as well to get financial support from Minister of Finance. The country has been able to issue some laws, some directives, but they are not implemented. For example, we have a law stating that the 40% of the import taxes on alcohol, tobacco, and sugar drinks should be allocated to the health sector, but as a matter of fact, nothing is allocated so far. So I wanted to lead you to one of the key questions we have identified in order to try to give sustainability financially, because in this phase we have to find out the added value. So how we can demonstrate the added value of the community health activities. How we can demonstrate which is the role of community health workers in the reduction of, for example, maternal and child health mortality in Guinea-Bissau. We have been experiencing an improvement of all the main MCH indicators. We know community health has played an important role since in 2013. The network of community health agents has been reactivated. So in the last 12 years, the constraint, the challenge is how we can get evidence-based results to show this added value. We need this to mobilize resources at external level, but also, of course, to mobilize resources at domestic level. This is really a key question. Next, linked to this reflection, we have identified a set of steps which can help towards a more sustainable community health. And the first one is this one. So try to carry out an evaluation. Of course, it has to be from an external independent source. An evaluation of the last 15 years of community health activities to document this added value. We're going to explore this option. There are other steps which can be identified. One is already ongoing, is led by our main partner WHO, we are elaborating a new and innovative health financing strategy to increase the fiscal space for health. We also need to institutionalize the community health workers and to integrate them in the Ministry of Health database, though it's not foreseen in the present National Development Plan. So there is a misalignment. It's a challenge. We have to work strictly with the government. The non-monetary incentives was the best practice in Guinea-Bissau in the past. It was interrupted, unfortunately, but the country has an experience. This can help in reducing the costs in a situation of scarcity of funds. Another path, another step, of course, is the possible creation of a primary healthcare directorate, Ministry of Health, like I believe some other countries have already. And so to strengthen the link and between the community health, the field and the peripheral health infrastructures. This is also key. The traditional healers are playing also an important role in West Africa, Guinea-Bissau especially. They can be linked, they can be involved in the community health activities. UNDP led a pilot project about the mapping of these traditional healers in Guinea-Bissau in the last 2 years. This is also a path, this is also a step which can be and will be explored in the next future, in the next months. Last but not least, we are in a key phase now because we are going to carry out the evaluation of the present community health national strategy. This will be carried out by UNICEF and by some external consultants. We should be connected, by the way. We should join the call. And we are going to elaborate the new community health national strategy for the next 4 years. This will be an opportunity for the government and the financial and technical partner to sit down, to open a national dialogue, to brainstorm about all these challenges and the possible solution, the steps towards sustainability. So that's the situation I can describe at Guinea-Bissau. You can go next slide. So we are happy to having shared our situation, our challenges. And of course, at the same time, we are here to learn from any other best practice implemented in our developing countries. So we thank you, as we say here, muito obrigado.
Thank you very much, Andrea, for sharing those insights all the way from Guinea-Bissau. And once again, if you have any questions for Andrea, please just share them in the chat box in the Q&A section, and we'll circle back to those questions during the Q&A session at the end of the session. Now, earlier on at the top of the hour, I had asked you this question as part of the Zoom call. We had asked the question, what is the biggest barrier to sustainable CHW financing in your country or your organization? To reflect on that and to share, and hopefully during the different presentations from the panelists, you're able to pick a few learnings, a few ideas that you can adopt in your organization or in your country from whatever level you're looking at it from. Just reading out some of the reflections that have come in over here. Lack of political commitment, especially in financial allocation, is one. Another person writes here that unclear CHW institutionalization under government ministry. And another person writes here, I think the biggest challenge is perception of decision makers on CHW's priorities. So keep them coming in and we'll keep reading them throughout the session. And now let's really double down on looking at how Africa innovative initiatives are financing community health with a real world example. And for our next segment, we're going to look at cross-country initiatives that have really made some bold moves in strengthening community health systems, and we'll be looking into the implementation of some of these initiatives and the lessons that we can learn from it. So I'm delighted now to hand it over to Yann Tapsoba, a health economist and health financing specialist at the Financing Alliance for Health. And he's also an expert in health workforce issues and public financial management, PFM. And through the initiative Africa Frontline First initiative, Yann has been supporting countries to strengthen community health systems, develop evidence-based strategies for sustainable financing, and has been working to coordinate CHW programs more effectively. Over to you, Yann.
Thanks, Maya. Good morning or good afternoon to everyone, and welcome. I'm so sorry I have to keep my video off due to connection which is unstable. I'm so happy to attend this symposium as I believe that it is a great opportunity for us to take one moment to reflect together on how we can sustain and we can strengthen the of CHW financing system. I think my presentation could be summarized in 3 main points. First, I will present who we are and what are our successes in IFF. Secondly, I will present the key findings resulting from our key activities implementing in our supported countries. This refers to the annual maturity assessment of CHW system and the resource mapping exercise in community health. These findings are initial and have to be taken carefully. Then I will conclude by presenting the key challenges that I think are very critical, and I will highlight the role of global health actors to address this challenge. Next slide, please. AFF is a catalytic mechanism which was created to strengthen and scale up CHW systems and to support the financing sustainability of their systems. Our vision by 2030 is to unlock $2 billion to train and deploy 200,000 CHWs with a purpose to ensure access to essential care for 1 million people. IFF is a coalition of 4 organizations supporting 17 countries, took a partnership with 9 strategic partners and six implementing partners. Next slide, sorry. Thanks. To our intervention, we have been able to unlock $240,000. In addition, this evidence is provided to our key activities, resulted in key action for improvement, such as additional investment in community health information system in Burkina Faso, Uganda, Liberia, and Sierra Leone, additional CHWs trained and recruited in Zambia and Ethiopia, as well as equipped and remunerated in Cote d'Ivoire. There is also the implementation of domestic resource mobilization, DRM mechanism, for fundraising in Guinea. Next slide. The maturity assessment is an annual exercise allowing the key community health stakeholders in countries to score the functionality of their CHW system, focusing on 8 components. First, governance, leadership and planning. Second, financing. Third, CHW remuneration, training and supervision. We have the community health management information system, surveillance and M&E. We have the community equipment and PPE and community engagement, right? Regarding the financing component, we can note that the component is partial functional in most countries and are stagnated at the same level. In Senegal and Cote d'Ivoire, the functionality of CHW financing system decreased to non-functional level. The only countries which are functional financing system are Liberia and Tanzania. This evidence shed light some bottlenecks suggesting to take action for improvement. I would like to say that most of countries do not have visibility on CHW funding gaps, have not a government budget line dedicated to the CHWs, and have inadequate and miscellaneous CHW funding with the government plans. To address this challenge, we support the country to conduct and to institutionalize the resource mapping in community health that should be integrated into the existing health sector resource mapping process, and to develop a costed national community health strategy with the aim to have a visibility on the funding gaps and to identify the key bottlenecks in community health systems to be addressed. We also support the country to design long-term sustainable financing plans for community health to define the key options for GRM and for a better management and use of existing resources. We support the country to institutionalize the CHWs and advocate for GRM and CHW integration into government budget. Next slide, sorry. The key fundings from resource mapping show some funding gaps, resource shortage, and an expected decrease in external resources allocated to community health. This could undermine the sustainability of CHW financing system, given it is dependent on external resources, which are expected to shift in the next years. It is the moment for us to think about what we can do and what we have to do to improve domestic resource mobilization, to reprogram the existing fundings in line with the national priorities, and to strengthen the public financial management. There are some windows for funding reprogramming. For example, in the slide, we can observe that in Burkina Faso, we will have funding surplus in 2026 that could be allocated to cover the gaps in other years or to partially reduce the total funding gap. In Guinea, we will have also funding surplus in health services delivery, which could be reallocated to cover the funding gaps of the other system domains. In some countries, like for example, in Cameroon, there is a need to initiate PFM reform to improve the government budget execution that could be an option to increase the government funding in community health. These evidences lead me to the final slide on the challenge and the role of the global health stakeholders. Next slide, please. I think, the CHW financing challenges could be summarized in 3 or 4 main points. Domestic resources mobilization increasing, not only from government, but also for the other potential national funders, like, for example, local bodies, private sectors, company, etc. There is the need to implement or to design innovative financing mechanism to ensure equity and effectiveness in CHW financing. I think about, for example, debt swap, which should be adapted to the context, the macroeconomic conditions and the debt profile of countries. I also think about health facility financing to direct funding to the actual needs of the CHW programs. The third thing that I have to flag is the reprogramming of existing fundings to target the highest priorities. This could consist in designing and implementing investment cases in community health to define the highest priority intervention that should be funded. Then the countries will define sustainable financing options for this intervention, took a long-term sustainable financing strategies or plans. PFM reform is or will be important to improve the use and the allocation of community health resources. Then there is also the fragmentation of external funding on community health. What could be the role of global health stakeholders? For me, is it to strengthen the technical assistance for countries for better coordination and planning of community health system, based on the national priorities, the advocacy for DRM in community health, engaging not only the ministries of health, but also the Ministry of Finance, the local authorities, and the parliamentarians. Last, it is to improve the alignment between external partners and with the government priorities. I think I will pause there, allowing the time to learn from you guys and maybe come again to respond to any question. Thank you, over.
Thank you very much, Yann. Now let's broaden the lens even further and get a regional perspective on this topic. I'm pleased to welcome our next speaker, Dr. Grace Achungura, who has been the regional advisor at World Health Organization Africa. And now currently she's the regional head for India, where she supports health system strengthening for universal health coverage. And her work really spans across domains, different domains, including universal health coverage, health financing, health systems, policy and planning, priority setting, resource allocation, and monitoring and evaluation of healthcare programs. She brings an extensive experience in health systems and policy across the Asia Pacific and also the African region. And she'll help us understand how global actors like the World Health Organization are supporting and are shaping a sustainable financing for community health workers using specific examples from India. Dr. Grace, over to you.
Thank you. Am I audible?
Yes, we can hear you.
Great. Good afternoon from Delhi to everyone, wherever you are in the different time zones. It's really a pleasure for me to present. And I want to say, I think the previous speakers have made the work so much easier for me, especially in presenting the global financing landscape. So some of the slides I will skip through because Elizabeth, Andrea, and Yann have done a pretty good job of summing up some of the key issues. Next slide, please. So largely, I want to start off by situating the discussion we're having on community health workers in the community health system, which ideally should be instrumental for PHC and UHC, attaining UHC, highlighting some of the key issues in financing for community health workers. I'll do a short case study on India, one country that has domesticated the financing for their ushers, their accredited social health activists through their community health workers, summing up a bit on the WHO guidance, marrying it with broader guidance on health financing and reflecting largely on the role of multilaterals. Next slide. So as the two schematics show, community health systems are composed of much more than just the community health workforce. You have the financing strategies that feed into that. You have the governance systems, the multi-sectoral collaborations, the supply that is critical for ensuring that the community health system is functional. And ideally, the community health system should integrate with the formal broader health system to deliver PHC, which, as we all know, is a comprehensive all-of-society approach that serves as an approach that provides the first point of contact for the health system for individuals and communities, ensuring essential services are accessible, affordable, and equitable, but also provides a platform that integrates integrated health services, multi-sectoral policies that will enable us to deal with the social determinants of health, as well as the empowerment of individuals and communities. So really, community health systems are critical for operationalizing PHC, and together they form the foundation for UHC and health security. Next slide. So the benefits of integrating community health systems, and I know that these slides will be shared with you, so I won't belabor most of the points, but basically We see them as cost-effective and equitable service delivery platforms that enable us to extend services to those that would otherwise be left behind, reducing barriers to care. They enable us to be able to respond quicker in emergencies, communities to adopt the emergency responses, and help us to also ensure continuity in routine service delivery. They increase health literacy and demand through increasing awareness of services, and also fostering trust in the communities. They can serve as entry points as well for multi-sectoral collaboration across education, nutrition, policy alignment. They can also foster continuity of care with the formal health system, and also help us build better surveillance data for decision making. Next slide. Now, when we think of financing for community health workers, we must understand what that entails for the community health workforce. The quantum of financing, as Yann has been talking about, that and many we have seen, is not adequate. Adequate financing sustains the community health workforce. It ensures long-term viability of community health systems and therefore action towards PHC and risk. The funding also influences the motivation of the health worker, which is critical for ensuring high quality service delivery and positive outcomes. The mechanisms, the modalities in which we remunerate the community health workers, and these communities well versed with the different forms that are deployed by different countries, the mechanisms, their reach, and the incentives built in shape the care quality, the outputs, and the priority setting within the community health workforce, which in turn affects whether you achieve your UHC goals. And lastly, the sources and the equity of funding also have an impact. Funding sources impact predictability. So we've seen with the US pulling out how that has affected many of the community health workforce programs. So the type of funding source will affect predictability, sustainability, equity, and the distribution of the community health workers. But also, it should be noted that the multiplicity of funders and how they organize themselves or manage may contribute to fragmentation of the financing landscape as well as the service delivery landscape. Next slide. Next slide. And so, as Yann has said, we have multiple sources of financing. We saw from the case of Sierra Leone and Guinea-Bissau, and also Yann's presentation, that very few countries are actually financing from their public coffers, the domestic sources. Most of the financing we are seeing is coming from external actors, both bilateral, multilateral, and now we are also seeing the big private philanthropic entity, Gates Foundation. We're seeing MasterCard coming in with different priorities for how community health workers are funded. And so then there is a need to see how working together, this funding can be harnessed in a more harmonized and coordinated way to ensure synergies to defragment the financing landscape. In low middle income countries, it tends to be dominated by external financing, and some of the case studies that have been shown here highlighted, but also there are no established accountability mechanisms, resource tracking. So for the formal health system, for instance, we have the system of health accounts that enables us to see how much money is coming, where is it coming from, who is it paying, what is it paying for, but we don't have such a systematic mechanism for the community health system, let alone for community health work. So we don't have visibility in the amount coming in, the allocative and technical efficiency of that line. Next slide. So I just want to present a case study of a country that has more or less domesticated its financing, and this is India, where I am. So within India, we have the country targeted 1 million ashas, and they have reached that target. And they have a mix of incentive mechanisms to reward the activity of the ashas. So they have monetary incentives. They have a fixed monthly payment of about $40 with additional performance-based incentives, which I'll show in a minute. But some states, as you know, India is a federal government, so state health is a state subject. The states are the ones who mainly implement the health policy. Some states like Andhra Pradesh have fixed monthly payments of about $110 with a few a much smaller list of performance-based payments for their ushers. Within the Ayushman Bharat flagship, there is a flagship on primary health care, which is to ensure a comprehensive package of services, both maternal child health, communicable and non-communicable diseases is delivered by PHC teams. The community health worker has been integrated into the PHC team. The team receives team-based incentive, of which the community worker also receives a share amount of about $11 in performance. They also have non-monetary support, as you can see, uniforms, bicycles, and the like. They also have recognition and retirement benefits. So every usher that completes 10 years is given 500, almost $600 as to pass out, and also even citation acknowledging their contributions. The government has put in place social security schemes for the ushers as well. So the first one is an accidental death fund that it pays out almost at least $2,300 for every usher who has such a challenge. There's a similar one, same amount for permanent disability. They have a pension scheme which pays about $35 per month after 60 years, and this pension is contributed to 50% by the usher, 50% by the government, and then they have the health insurance scheme as well that fully covers them and their families to a total of about $6,000 per year. And then this money is transferred through the public financial management system by what we call direct benefit transfer directly to the usher's account. Next slide. So I talked about the national programs, child health, maternal immunization, family planning, national vector resistance, TB and leprosy program. All of these have different indicators, and some of them are charged 10 rupees, some 25, some 50, others up to 1,000, and all these converge on the same CHW. So depending on their workload, some CHWs ushers may focus on the more lucrative performance-based incentives on top of the 40 USD that they get on average, and overlook some of them. So this is where some of these performance-based incentives may distort what you want. And if you were to use them, you design them such that you place more emphasis on those services you really want to purchase that will help you reach your UHC goals much faster. So this is just 4 pages of an 8-page document summing up the volume of indicators across the programs. Next slide. So WHO recently did a review on the community health workforce and came up with a guideline. This was really looking at the planning and the different aspects of the management of the community health workforce, including remuneration. And one of the things that we emphasize is that sustainable financing for the community health workforce, we see it as critical for implementing PHC for UHC and also health security. It should not, however, be the beginning part of the discussion, because we see it as instrumental towards achieving an end. And what is that end? Every system is designed with policy goals around financial protection, around health and well-being, responsiveness, and the like. And so that should be the crux of the discussion that then guides the service delivery mechanism to ensure that you deliver the services that you want. After the service delivery mechanism is defined, including the role of the community health workers and the numbers therein, then the financing discussion comes. It is instrumental, but it is not the beginning. It should follow the service delivery discussion in order to ensure that the community health workers are able to deliver according to the service delivery design for the system goals that you want. And so the WHO guidance, just summarizing it here, strongly recommends that countries should prioritize financing for the community health workers, remunerating them according to the commensurate with the job demands complexity, the number of hours, the training, and the roles they undertake. And it suggests, so this is a conditional suggestion, it suggests that they are not paid exclusively using performance-based incentives because of the perverse effects that they have in terms of skewing, distorting priorities, but also in some ways can also act to disincentivize the workers. And also it recommends that financing for CHWs to be situated within long-term planning and financing of the National Health Workforce Strategy and embedded in the planning for PHC and choice. I believe I'm going to my last slide. So just like Yann, I'll reflect very briefly on the role of the multilateral development partner. I see it more as a place where they inform the agenda setting for governments, especially where there is very little understanding of the role that they can play, but also where there is very limited political will. So agenda setting, helping to frame the issue again within the government's broader development and health system goals, and to support with the budgeting, the planning and the budgeting for CHWs within PHC and UHC. I think also there is a role for providing evidence on the best options for health financing. So for instance, in Thailand, they have the Health Promotion Fund, which comes off a tobacco levy. And that fund is supposed to provide for health promotion and prevention activities. Countries that are constrained on fiscal space and there is room for taxation within harmful health products like alcohol, fossil fuels, for instance, or in trans fat acids, things that are counter to our health. There is room to tap into places like that. And once those funds are mobilized, such funds can also be used to help support health promotion activities and to finance CHWs. Also, I see that they play an important role in catalytic funding, as we have seen from Andrea's presentation and from Elizabeth. But that should not be the end of that discussion. And I think this is where Africa First, the Frontline First, should, beyond mobilizing the 2 billion, should engage with governments, working together with other partners to make a plan for the domestication of the financing beyond what is catalytic in setting up the CHWs. While they made, for instance, the front load costs of investment, training and all, how then does the government take on the role of sustaining? And lastly, developing the resource tracking and other accountability mechanisms and their institutionalization. Thank you so much.
Fantastic. Thank you very much, Dr. Grace, for that. We've heard from the government. We've heard from the perspective of development partners, implementing partners, donors. And of course, we cannot continue this conversation without having the perspective of a community health worker, the heart of everything that we're talking about today. As our presenters have said, community health workers play a very crucial role in forming a foundation of effective people-centered primary health care. And they are delivering essential services where health systems are at their weakest. Yet, there's a huge challenge when it comes to them being funded. They've been underfunded. And now, with the shocks of the global health financing landscape, their work is even at greater risk at the very moment when we can arguably say it's most needed today. But don't take it from me. Let's hear it from a community health worker. That's why I'm truly honored to introduce our next speaker. We have Resi Budiana, a women's advocate and a community health worker from Indonesia. She will share firsthand personal experiences and insights into what it means to deliver on-ground services, the challenges that community health workers face, and what sustainable financing would look like from their perspective. Resi, welcome. Over to you.
Thank you so much for this time. Hello, everyone. My name is Resi Budiana. I'm from Senaru Village, North Lombok, West Nusa Tenggara, Indonesia. Without further ado, so I want to next to presentation slide 1. So if you ask me what is the biggest financing challenge in program involving community health worker, the answer would be the community health worker system here in Indonesia. Unlike most the health system in the world where community health workers are delegated under the Ministry of Health, Indonesia has unique bureaucracy and which community health worker, although assigned and mandated to the carry out health tasks, are administration under the authority of the village government. This means that the all funding process for the activities related to Kader Posyandu or community health worker, from recruitment to incentive payment, are decided and managed by the village. As a result, there are the three main actors responsible for the community health worker. First, the village government, and the second, the health worker, the community health center, or we call CHWs. The main challenge in the practice is usually the gap in understanding and expectation between the village administration and the health sector. Ideally, the village and the community health center, or we call puskesmas, who always the align and their understanding, but the course is not always the case. For example, the Ministry of the Health now requires community health worker to master 25 basic skills. This is not small task. Community health worker need the extensive training and supervisor to carry with those duties. And we also need the various health screening tools such as blood pressure monitors and like cholesterol, glucose, and many kind of the like screening we do in the posyandu. We call posyandu in pos, which are not the owned by the very community health worker or the health posyandu. Anyway, not everything can be implemented. When there is dialogue and the mutual understanding between the village and the we call puskesmas or the community health center, funding should flow smoothly. However, in Indonesia, the village had its political leaders, which mean they have populist interest, political priorities on often out and communal health needs. For example, community health programs may not prioritize and therefore receive to funding. Even non-national and professional regulation exists. If the village does not prioritize, this program is not difficult to implement effectively. Next to second slide, please. Thank you. My second slide is about advocacy. For sustainable funding, advocacy and financing go hand in hand. You can have to without the others. That's why I encourage you the community health work and join meeting at the village, sub-district and district levels. These are not the places where the policymakers see and decide how our program will be funded. Even non-national policies set aside the share of the budget for health, that money isn't always used for the community health worker programs. Physical projects like building toilet or the buying biscuits often look more attractive to village leaders because they are easy to see and show off. Training community health worker, on the other hand, doesn't give instant, visible results for many decision maker. Biscuit and solution, like 6 years. There's the problem. Who will use the toilet for if the people have practiced of the defecation for the years? We need skill. While training community health worker to educate and guide communities to set the new facilities and actually use. That's why budget for the community health worker program must be protected and fought for. When community health worker program are underfunded, we miss out the on-proper training and the skill needed to do our jobs. If funding for equipment that is cut, we are forced to work with what little we have, which can lead in the inaccurate measurement and data. Inaccurate data means people might not get the right referral, the nearest health center, the treatment they need. In the end, this weekend primary health care at the community levels. Next to second slide, to 3 slide. Thank you. And this brings me back to the importance of the advocacy. I have seen its impact in my own village after the 1,000 Days Fund trained us. They help us for a far intensive like incentive when the village had the benefit the right training. He set aside a budget for the continuing community training and coming years. This kind of local ownership is what makes funding really sustainable. The 1,000 Days Fund also work at the district levels. For the first time, the village fund guidelines include the setting minimum community worker incentive of about 12 USD. Before that, it's called as low as 3 USD months, far too little for the work we do. With my Ministry of Health now requiring higher standard, the amount is simply not human. Community health workers spend 50 to 60 hours, even more, every month on this work. And many of us, the mothers with family to care for, we can keep him volunteering without fair pay as demand for our skill increases. We deserve decent, reliable compensation. Next. This is like innovation in other like in Java, not in Lombok, yeah. Indonesia, a good example of the community health worker funding that is well integrated into the PHC program, come from Surabaya, a city in East Java. They have program called we call like Kader Surabaya Hebat. The program is let be the mayor and set a strong example for the other region. The mayor is to clear regulation that include the benefit for the community health workers, such as the monthly step of about the 500 around the 33 USD. I believe this amount has now doubled, making in one of the highest incentive in the country. Even better, community health worker, they also get free coverage under the National Health Insurance Program, or we call BPJS, something we don't receive in many other places. This kind of support excellent and should be copied and back my mayor and district leader across in Indonesia. Yeah, next to the other slide, the last slide, yeah. In the last slide, overall, I believe funding is one of the biggest challenges for the smooth primary health care. peace program. Thankfully, NGOs like 1000 Days Fund saw the government how to can work. They design their program to fit the Ministry of Health plan and help bring those plan to life. They train health workers so they can train and supervise community health worker and provide us with the useful tools, including digital system to track data. Recently, they organized a Gebiar Posyandu or the Health Post celebration. Thank you so much to recognize community health worker with the best performance. This kind of appreciation and recognition is something we as community health worker really need. So I have many inspiration also in when we like a community worker, because here we stay in the village, Senaru village, like under of Rinjani Mountain. In my village, we have like 15 hamlet. One hamlet, we have targets more than the 1,000 persons. So we come to Posyandu, we call Posyandu. So many problem also, but we have solution. But here in our government, it's like, it's not yet balanced, yeah. Like capacity building and the physical building is not yet building, but when the 1000 Days Fund come to support the capacity building for the community health worker, so be changed now. So thank you so much for the opportunity. This is my dream. I can share for you all. So I have also dream, not just me. I have many resi and many community health workers we can share again. So thank you so much and bye.
Thank you, Resi, for that amazing insights. Now, we are going to give some time for you to have your questions answered. A lot of you have already put down your questions on the Q&A chat function, and our panelists have been answering the questions on there. So have a look at the chat box to see if your questions have been answered. But I'd like to throw this question to the panelists, and any panelist can take this question. It's a very, very good question here from Yann. Yann writes here, since community health workers are considered as low-skilled workers, and with AI getting more popular, getting more efficient, what could be calculated scenario of considering health financing in case the funders change, prioritize over AI to substitute community health workers in the future? A great question there, as we're seeing AI being adopted more and more, and in general, digital health being leveraged across different governments. I'll throw that to any panelists that would like to tackle this question on what this means for governments, what this means for community health workers, what this means for donors when it comes to adoption of AI. Anybody feel free to take this up, please.
Yes, I'll just speak briefly to I think Thailand is a good example of the role that community health workers can play in driving demand for digital health tools that enable faster service delivery and of good quality. In Thailand, they do have digital health literacy activists, I believe they're called, who work at the local level and within community, apprising the citizenry of different health apps, tools that are critical for them. And also, so that helps them. In India here, they also help in the people who do not have good skills, particularly the elderly, to engage in what is called the Ayushman Bharat Digital Mission, to get their personal health records, the ABA IDs. And those personal health records then facilitate continuity of care between different providers. And so that has been one of the ways in which they've helped to scale up one, the awareness of the personal health records, but two, the adoption of the personal health records, which the government is hoping will be critical for ensuring integration and continuity of care. I think AI, I see it more as a way of harnessing the information that can potentially be generated at the community level, if well harnessed within a good information system to enable us to then make sense of emerging disease patterns, local health priorities, for example, within villages or sub-districts, whichever nomenclature applies in a certain context, in order to then inform evidence much better. So I think those are some of the things that quickly come to mind. Thank you.
Amazing. Another question here reads, do you think it would make, I would say efficient, would it be more efficient rather to incentivize community health workers together with other areas like social welfare or an integration to maximize the result amid a financing limitation? For example, community health workers may not only work for only health, but also other administrative or social welfare tasks. Any experiences or successes or failures because of this integration? Again, throwing this out to any panelist who would like to take up this question. The question on, how we can incentivize community health workers, different methods, different, ideas on how we can incentivize them, and any key lessons that we can take based on experiences, country level or regional level.
Okay. I see Elizabeth's hand up. Maybe you could go first.
Yes, Elizabeth, please go first.
Okay. Looking at the load of work that CHWs are currently doing, not only in Sierra Leone, but also in other countries, there is so much demand on CHWs in the health aspects. And so there are even some programs that want to utilize CHWs to implement their programs at community level, which we are restricting for the moment because CHW cannot do everything. So in as much as we want to, we should also consider the workload that we give them. So in my own opinion, and in the perspective of Sierra Leone, I will prefer that we concentrate on the health aspects for community health workers, and for the social aspects like social welfare. That one can be delegated to community health members or community health promoters within the communities for a short while. But for a professionalized community health worker, I would prefer that we just give them the scope of work within the Ministry of Health. And although they are also doing some social work within their work, there are some aspects of social work, but I recommend for them to have additional workload. Maybe we will have to look for other innovative ways of financing them. There are so many innovative ways if only countries can adopt. And that's why we have partners like Financing Alliance, Last Mile Health, AFF. They are all there to guide us on how to mobilize additional resources that can be allocated from primary health care and specifically for the community health worker. Over, yeah.
Thank you, Elizabeth. I'd like to give Dr. Grace a chance to respond and to add. Is there anything you'd like to add to that as well?
Yeah, I think it shouldn't be a one-size-fits-all. I think it should be based on the country's context. Again, going back to the UHC goals and they fitting it within broader health workforce plan. So where you have cadres that can comfortably take on some of these broader social determinants of health at that level, that would be okay. But where, for instance, depending on how you design your community health worker program, there is room to incorporate one or two critical indicators that can help drive the some action on some social determinants of health, especially those that you see are critical in nudging progress in certain areas, for example, in cholera endemic countries, or, where diarrheal diseases are still a challenge, then there is scope to incorporate them again based on the context. And so I'll give an example here in India. The government over the recent years ran what they call the Swachh Bharat mission, which was really about ending opioidification. And so part of the CHW's incentives was to get the homes to adopt better toilet practices, and also to connect to tap water. On the nutrition side, they've also included an indicator on salt testing for them to ensure better incorporation of iodine, in the salt. So it really can't be a one size fits all. I think it has to be really informed by a good review of the system, what is feasible, and then what the government really is targeting to hit. Thank you.
All right, I think we have space for maybe one or two questions. I think from the presentations and also from the responses from the participants, there were a lot of questions raised about the need for stronger evidence for advocacy as well, and how the two go hand in hand for sustainable community health worker financing. So I'd like to throw this question over to Andrea. When you spoke about the stronger evidence that is needed on community health workers' contribution to health outcomes, to maternal and child health, if we could generate one piece of evidence right now that would convince the Ministry of Finance to allocate funding for community health workers in Guinea-Bissau, or even just beyond for different countries to adopt, what would you suggest it should be?
Thanks for the question. Well, I do believe we have to start from an independent external evaluation of the program of community health activities. So it's something it was not done yet here in Guinea-Bissau, but maybe some other countries can bring some best practices. For instance, countries where the community health network is not implemented nationwide, maybe in some pilot health districts, health regions, and where we may experience a better MCH indicators, talking about, for instance, antenatal consultations rate, assisted deliveries rate, immunization rate for children. So if you can bring up some evidence that in these health district regions, where the community health network is fully operational, we have better MCH indicators than in districts which are not yet covered. And this can be assessed independently and externally. This really could be a piece of evidence which can be key in resource mobilization, domestically and externally. Unfortunately, in Guinea-Bissau, we are not there yet. Even though we started community health activities in 4 out of the 11 health regions we do have. So we may try to go backward and find out, but it's a question I'm raising to, is there some country who managed to bring evidence comparing, health regions where the community health network is fully operational with others which are not yet there? Thanks to everybody. We're in a landscape scenario. Everybody's scrambling for resources. There is a scramble for resources, and within the Ministry of Health, as we know, in this scarcity, in terms of future scarcity of funds from external, there'll be a struggle to allocate resources for Minister of Finance. So I really do. The only way we do have is bring up evidence that our community health agents are really key to improve, especially, primary healthcare in the case, especially mother and child ones. Thank you.
Thank you so much, Andrea, for that. Even as we spoke on social welfare, I just want to read this comment out from Nono, who says, we in Shan State need a lot of health services and education services, economic activities and livelihoods for the ethnic people. And it's interesting to see projects that look into that as well, in supporting community health workers and giving them incentives in terms of access to loans or access to savings as a way for them to have a livelihood or to have some income generating activities as an innovative way to financially to finance community health work. Elizabeth, you have your hand raised. Is there something that you'd like to add before we close real quick for a minute maybe?
Yes. First of all, I just want to add to what Andrea have already said, that a lot of countries have used investment case. They have made a case using a lot of sources of data like the CHWs, the demographic health survey, and to generate ROI, return on investment. This is to showcase the benefits that will be derived from investing in CHWs and comparing it to what the country can lose if we do not have a community health worker in the country. And so this one has been very effective in some countries, and that is what Sierra Leone is now working towards, trying to get the investment, the ROI and the investment case to advocate to Ministry of Finance. And if you have a very strong ROI, I think the ministry or the Ministry of Finance or the government can consider investing in CHWs. And also, for the other, what you said just now, Maya, for looking at other ways, alternative ways of generating funds for CHWs, like income generating, entrepreneurship, and currently we are looking at that one from MasterCard Foundation that is going through UNICEF. So this is the first time we are going to do that one to ensure that CHW have additional funds, whether they are put on salary or they are not salary or they are incentives, but they have other ways of getting funds or financing that will help them to support them and to ensure that they are retained. That will improve on the retention of CHWs.
Fantastic.
Yeah.
Thank you, Elizabeth. Thank you so much for that. All right. So ladies and gentlemen, thank you very much for joining us. We've heard from our speakers. Thank you for your active participation, for your questions, for your comments. And we really do hope that this webinar has given you a clearer picture of community health financing, where the effort stands today, what's still missing, what can be done, practical ideas and models for moving forward, and also a deeper understanding on how global health actors can coordinate more effectively and help build resilient primary healthcare systems through community health workers. At the beginning of the webinar, we had asked you the question on what do you think the biggest barrier is to financing community health worker programs. And now as we close, we want to think about what our call to action is. So the question that we're asking over here is, what one shift you think, given all of the different perspectives that we've discussed today, do you think that global actors can make to better support community health financing in 2025 and beyond. Share some of your perspectives and ideas there. And even beyond this webinar, I would encourage each and every one of you to think about the role that you personally can play, big or small, to make that shift happen. So that brings us to the end of our webinar. Thank you very much for joining us. This event was co-hosted between Community Partners International and the Financing Alliance for Health. Being the communications lead at Financing Alliance for Health, I cannot end this webinar without telling you all to visit our website, financingalliance.org, to learn more about the work that we do, even on Africa Frontline First that Yann had presented on as well. And also connect with us on LinkedIn, Financing Alliance for Health. Once again, my name is Maya Hayakawa. I've been your moderator for this webinar. Thank you for having us. And I'd like to pass it back to Sia for closing remarks. Until next time, goodbye.
Thank you so much, Maya. And thank you to all our speakers, partners, and especially the participants for today's rich discussion. The insights we've heard bring us closer to ensuring sustainable financing for community health workers, I believe. Once again, the webinar resources will be shared in a timely manner to all registrants. This includes the webinar recording as well. So once again, let's carry this momentum forward into our next webinar on climate change. Frontline resilience, how community health workers are responding to the health impacts of climate change, which will take place next week on the 24th of September. As well as if you are looking for dynamic conversation sessions similar to these, feel free to subscribe to our mailing list to get less updates and news about the symposium, which will take place in November. So we look forward to seeing you there and continuing these vital conversations together. Thank you so much for joining us. Until next time.